probably make some one or two messages for the residents, I guess. Hi, ma'am. I can see
Hello,
Dr.
Aman.
Kali there.
Welcome, Ji.
Thank you, ma'am.
We are looking forward.
Oh, thank you. Same here.
Yeah.
Looking
Wonderful.
forward to the discussion.
No, it would be very interesting.
So let's
Aman,
see.
can these biologics be given without immunosuppression also?
Without,
For that antibody production thing, what's the latest?
without immunosuppression means what? Yes, I mean there are some which can be given. There are some which can't be. I mean, if anti-drug antibodies basically depend, the concept is basically depends upon the underlying disease also. Rheumatology literature, whether there is underlying rheumatoid arthritis or angstmon, there are certain diseases in which people combine, like rheumatoid, and there are others like spondyloarthropathy, which the people don't really generally combine. So basically, it depends
And
on the underlying disease also. There are
so
two.
if we are giving for purely ocular purposes, probably we always do not need to.
You may not, yes.
Okay.
You
So
may not need to. Especially upfront visits. I mean, maybe I'll talk about it during one of the.
ठीक है.
Yeah.
So Diksha, you can take over.
Yes, ma'am. Good afternoon, ma'am. Ma'am, can we start? It's like it's 2 o'clock.
It's 2 o'clock. Please start.
So, very good afternoon to all. In today's MCH Video Retina class, it is my extreme proud privilege to have Dr. Aman Sharma, who is speaking to us, going to give us an overview of the immunosuppressive agents that are used in uveitis. Just to introduce Sir to you, Sir is Professor Clinical Immunology and Rheumatology Services in the Department of Internal Medicine at PGI. He has several important achievements. He is a member of the annual meeting and planning committee, American College of Rheumatology. He's an expert reviewer from ACR, ULR classification criteria for GPA, MPA, EGPA, and Takayasu arthritis. He's the member board of governors of Physician Research Foundation. He has several named awards and orations to his credit, including the Rabindranath Tagore Oration 2019, IRA Oration 2015, R. Subramaniam Endowment Oration 2015, Shurvi Trust Visiting Professorship 2014, to name a few. He has 374 peer-reviewed scientific papers and 56 book chapters. Special areas of interest include systemic vasculitis, psoriatic arthritis, relapsing polychondritis, and SLE. He has several textbooks, including a textbook on systemic vasculitis, one on tropical rheumatology, then urgencies and emergencies in rheumatology, psoriasis and psoriatic arthritis, and spondyloarthritis. He's the founder of the Indian Vasculitis Registry and Indian Relapsing Polychondritis Registry of India. And sir, we have known because whenever in the uveitis clinic, right from the time when we were junior residents with Professor Amod Gupta, where you would come on every Monday and you would see all the uveitis patients and give your expert opinion, sir. And even till today, whenever we have to refer a patient and we have to seek a second opinion, we always send to you, sir. And so your interest in uveitis we have known for so many years, and so it's a sheer honor to have you, sir.
Thank you so much, Dr. Diksha, for such kind words and for the kind invitation to discuss a topic which is very close to my heart. With Eye Center, this has been a very cherished association right from the days when Professor Amod Gupta sir asked me to start coming to the uveitis clinic. In the beginning, I think it was a mixed feeling. To fill into the shoes of a legend like Professor Bhambri was something which seemed to be a challenge to me. But over the last 13 years, it's matured into such a beautiful and most cherished relationship and association in this institution. This is something which I always in the past looked forward to, and even now, whenever we see something unique and we see something challenging, it's always, it excites. Although it's been 13, 14 years, but I feel it's the same as it was so many years ago. So basically, I was told to give an overview, and in the beginning, I would thank Dr. Vishali and all other people for the, Dr. Rima is there, and I can see other people also, for the association that we've had and for this opportunity. When I was asked to talk about it, the two things were there in my mind. One was to tell and provide all the data, or the other way was since it was primarily for the residents, the way it would be done in the clinic. So as I was told, I've chosen the latter, and I've chosen how the decision should be taken in the clinic. And with this in back at the back of my mind, I have taken this. These are just my disclosures, and this is the layout of the talk. Basically, when do you give an immunosuppression? Which one do you choose? Corticosteroids are still the backbone, and many of the times the slides are made are based upon what the residents miss, or when we see the resident have started some therapy, and how they could have done the things differently. I won't say right or wrong, but I would say that how things can be done from a different perspective. Then how do we really use the synthetic DMARDs, and what is the place, and how do we really choose the biological therapies? So when does one consider, since our residents are also there, first few slides are largely targeted towards them. Basically, when there is a persistent or severe inflammation, or either there are contraindications or intolerance to other therapies, the rheumatology resident must understand that initially the topical therapies are the ones which are tried, and once they fail, or local therapies, then there comes the need for systemic immunosuppressive therapy. And whenever there is a need to have steroids more than 10 milligrams for containing the disease, then there is a need of a maintenance immunosuppressive therapy. And biological therapies, when the disease is inadequately controlled with corticosteroids and non-corticosteroid immunosuppressive therapy. But there are caveats to this. These can occasionally be used upfront. So what are the indicators of severe inflammation? Obviously, when there is impairment of visual function, if disease is bilateral, if there is some vitreous haze, macular disease or optic disc nerve disease, retinal inflammation, macular edema, exudative detachment, or ocular structural complications which threaten the visual function, or when there is recurrent or chronic disease. This I have taken from the Focus initiative. This is just for you, for the students to look up. Again, these are the ocular and anatomical reasons. And then wherever, as I've already alluded all of these, therapeutically, there is a regional failure to respond to or steroid injections or topical corticosteroids, as I've already alluded to, or when there is a systemic failure, when there is acute uveitis while taking a higher dose of corticosteroids, or when the steroid dose cannot really be decreased. This is just a reiteration. And steroid intolerance or steroid sparing, when there is severity of the disease, or there are poor prognostic factors for vision loss. So these I've already explained. So coming back to what I've been told to discuss. So the background generally is corticosteroids, and then there are different classes of drugs which are antimetabolites, T-cell inhibitors or calcineurin inhibitors as we call them, alkylating agents, which are one of the most potent but also one of the most dreaded because of the side effects, and also biological agents, the ones which are in the general practice. And I've intentionally not included small molecules because as of now we don't really have enough evidence, and many of the molecules which are discussed in the text, either they don't have position or they don't have availability in India. So I will go over them one by one. I'll start with corticosteroids. For the residents, they are all aware that we use methyl pulse 1 gram for 3 days whenever we need an immediate control. But one thing which is occasionally missed and which must always be done is that whenever we use methylprednisolone for 3 days, this must almost always be followed up by corticosteroids, 1 milligram per kg body weight. Many times we see that this is not occasionally done. or more commonly, we used prednisolone 1 milligram per kg body weight for a maximum dose generally of 60 milligrams per day. And we start to taper sometimes between 2 to 4 weeks and sometimes after 4 weeks. And the target is generally 7.5 milligrams per day. But one has to remember that as we go up from higher doses, the increment of the tapering is higher. As we come to the lower doses, the tapering is at a lower dose. The most important thing that I wish to tell here is that although methylprednisolone oral tablets and deflazacort tablets are in vogue in the market, but we don't really prefer any of these. These don't have a proven advantage over either the common prednisone that we use. The other thing that one sees that is important but is occasionally missed is must get the blood pressure checked at the baseline and the blood sugars checked, and they must be monitored every 3 months because this must be registered in the mind that these have to be checked, because many times you would see these are missed. And then one has to look at the lipids, one has to have a concentration on bone health. Osteoporosis is very important, especially if the elderly patients are there, because you might take care of the eye, but the elderly person might break his bone, and neck or femur fractures, the mortality rates are very high. So don't really be dismissive of these things. Calcium supplementation is a must. These are also occasionally missed. So calcium supplementation along with the vitamin D supplementation has to be there whenever we give corticosteroids, and make sure that there is no active infection anywhere. Just a cursory asking whether there is any fever or any other localizing symptoms. It's not a bad idea to ask about these for the residents, and must discuss with the, especially if you're starting steroids with any patient, more so young patients, young females, must discuss that these might have some side effects in the form of facial or body appearance. There might be rapid steroid taper regimes, and you can use other drugs. So these are the things which you can occasionally, you should discuss with the patients, and must always tell that they should never abruptly stop steroids, because if there is a suppression of the hypothalamo-pituitary axis and they suddenly stop steroids, which can happen unless we tell them, then they can land up in trouble. And also we have to take care and keep in mind that children less than 15 years, there will be delay in the pubertal growth if the corticosteroids are used. The other side effects which one has to be aware, that sometimes patients will come with a lot of anxiety. The patients may come that I am not able to sleep ever since you started me on steroids, and there might be depression or there might be mania occasionally. These might only be because of corticosteroids. So there can be easy bruisability. So if there's some, skin becomes thin, there may be easy bruisability. But if you use steroids for a long time, almost all of them are going to have it, and there's nothing much that you can do about it. And there is also going to be poor wound healing. The other important message that I have for the residents using IV methylprednisolone is that must remember, most of the time nothing will happen, but occasionally there might be arrhythmia, there might be cardiovascular collapse, even MIs and severe infection. So ideal settings, you should be giving them under at least where monitoring can be done, and also never give it very rapidly. Always give it over a period of time of half an hour or longer. If you give these faster, you might end up having a catastrophic outcome like this occasionally. Less common, but have to be kept in mind, are pain abdomen because of pancreatitis, aseptic necrosis of bone, worsening of diabetes, myopathy, and psychosis. I've already told you. Ulcer disease is not very common if you only use corticosteroids unless they are concomitantly being given NSAIDs also. Shared decision making has to be there. Tell them that, the question that is often asked and probably is going to come during discussion is, for how long do we treat? When do we really stop? And I think if we have to tell this upfront to the patient about the chronic nature of uveitis, and that you may not say this is lifelong, because it may not be required lifelong in all, but for many patients it has to be given for very long. And this thing has to be discussed with the patient in the beginning. I'm borrowing these, why I'm brought this slide was even in the, we don't know really what is the optimal dose in vasculitis. If you look at various different recommendations over a period of time, some use 60 milligrams as maximum. Focus Initiative also tells 60, some say 80, some say high dose, they don't really mention. And people tend to target not less than 15 earlier. Now they are tending to target to 7.5 milligrams at 3 months. But one thing which is very important, and one thing which you have to register in your mind, is that we are definitely moving towards lesser doses, and even trials are on where in vasculitis research people are looking at 0.5 milligrams versus 1 milligrams and what would be the outcomes. Japanese studies on, and we have also realizing now that steroids are a bigger cause of infection than some of the drugs that we use. This is known in SLE, and this is also realized in vasculitis. So probably it is not the other immunosuppressive drugs, but these are steroids which are a greater cause of which contribute more to infections. So again, just to drive home the point that the target prednisolone is 7.5 to 10 milligram. This is what all rheumatologists have been teaching, but doesn't really always happen in the real life. This is trial data where the things are done as per the design, but even in the trial data, it is not really achieved as what we envisage and what we treat. It's at 30, 21 weeks, not at really 3 months. So this is what the ophthalmology literature shows us. These are there are two types of tapering regimes, which are rapid versus slow. Again, I've discussed where these can be considered. But one thing very important is from 60 to 30, you can decrease by 10. But if you go back, I'll show you. If we, probably I'll come to, there's another one. So if you see, this was a published study published in New England Journal of Medicine earlier, the PAXI-VAS study. What it showed that reduced and rapid taper, here you see from 60, immediately people come to 30 in the next week. So you can straight away come from 60 to 30, and probably all seniors would remember that this is what we have also been doing once we have had a need to decrease the steroids quickly. So there is no one rule of thumb, but I think this is this is the direction in which we are moving. And that is what you have to understand. And you have to, the other thing which is important is that you might get a relapse once you taper. Then what needs to be done? You go to a higher dose for another 1 month, and until the disease is quiet, then start to taper off and keep it for just above the level at which the disease reactivated, and keep it there for a while. And probably if you're given immunosuppression in the background, you might increase the dose of that immunosuppression, because eventually you want to get rid of corticosteroids. So this is something which is very important. And also, again, just to tell the patient that the hypothalamus-pituitary axis may not return 6 to 12 months after tapering or stopping corticosteroids. The other important thing, which may not have direct implication to uveitis practice now, but may become relevant very soon, is this study, which is Avocapan, which is a C5a inhibitor. This is something which has been shown to have superiority over corticosteroids in treating ANCA-associated vasculitis in the phase 3 Advocate trial. These are this was presented at the ACR meeting, which finished yesterday. This protocol, either rituximab or cyclophosphamide was used for ANCA vasculitis, and the other comparator was Avocapan, which is C5a inhibitor, which is oral 30 milligrams, or along with a matching placebo. And if you can see, not only there was a non-inferiority at 6 months, but there was also superiority of Avocapan over corticosteroids. So this is something which is very exciting, and the buzz is around that these might replace corticosteroids altogether. Minded, this is not for replacing the basic immunosuppressive therapy in ANCA vasculitis. Like the backbone of ANCA vasculitis is either cyclophosphamide or rituximab. That stays there. But this might take place of corticosteroids. So I'm just sounding you that this might also become a reality in future. Early days, but very promising results. David Jane did talk about it in 2014 when he had come here for our IRCON meeting. Those were early days from 2014 till 2020. I think a lot has happened, and I think we are really very excited with these results. Now, coming back to the drugs that you wish all of you might be happy or be interested in listening about, I'll quickly go over one by one. But the message that I have is, remember, most of the immunosuppressive drugs take several weeks to have effect. Even cyclophosphamide given IV doesn't really start to work from 2 to 3 weeks. So it is the steroids which will work immediately, instantaneously. So we give a bridge of corticosteroids and then immediately give immunosuppressive therapy. And then basically depends whether you start with 4 to 8 weeks. If you are using things like azathioprine or methotrexate, you might tend to taper earlier if you are using more potent drugs like rituximab or cyclophosphamide. So that is why you might see a difference between the duration mentioned here and in the previous slides. So the other question is, which one do we use? Basically depends upon the underlying systemic disease causing uveitis and coexisting disease in other organs, and what is the local experience. This is again focus initiative. If you see, they've talked about inflammation control, visual acuity or stability, and steroid sparing effect. It is there in conditions with mycophenolate, mofetil. This tends to say, to project as if MMF is better than methotrexate and then azathioprine. Azathioprine in some situations doesn't really cause visual stability or proof. But many times people believe that this is because of lack of evidence, not lack of inefficiency. If you read what Jim Rosenbaum has written in Up to Date, they prefer methotrexate. They do not really prefer mycophenolate. And there are obviously, if you see, go a few years back, even the recommendation in Journal of Ophthalmology was azathioprine. So it's not that there is a clear-cut great deal of advantage of one over the other. And if you look at the level of evidence of practice, these are same for all. So I think you can use either of these depending upon what, we have to look at the cost factor, which is very important, and mycophenolate of all these three is the costliest. So many of our patients are not, even if we wish to, are not really able to afford mycophenolate mofetil. Azathioprine and methotrexate, well, probably methotrexate you can use, it can be given for pretty long period of time. It is used in rheumatoid arthritis for as long as many patients, they take it almost for lifelong. There are some concerns, but there are certain more concerns with azathioprine, especially long-term, very long-term hematological malignancies. Risk is a shade higher. Although if you look at the data in uveitis, that has not been substantiated in Doug Jabs has written in one of the write-ups. The references are there towards the end of my talk. You can all look up at details of what I'm talking about. But this again would depend. Then they've talked about cyclophosphamide. For sure, cyclophosphamide is effective and very potent. But here also it says visual acuity or stability, we don't really know. But these are more because of not many trials really have been done to look at those. And then we practically never use chlorambucil. We use cyclosporin. We use cyclosporin a lot in Behçet's disease because the previous EULAR recommendations for retinal vasculitis, they recommended use of cyclosporin plus azathioprine for retinal vasculitis. We haven't really used tacrolimus in many patients. We've used it occasionally in rheumatology, especially muscle diseases, and occasionally ANCA vasculitis, but not a great deal, but we do use. We have never practically used chlorambucil, and most of the other institutions also, they don't even mention about it. So coming back to the most important thing, whenever we have to start immunosuppressive therapy, one thing one has to remember, that it's not that you can just write it on the card without having the basic investigation done. The residents must remember that we have to, it's obligatory on our part to have at least hemogram, ESR, platelet count, LFTs, RFTs, fasting blood sugar, urine routine, chest x-ray. Chest x-ray is almost chest x-ray and MON2. Somebody asked a question in between. MON2 is already done before we talk about. PJ is a global leader in TB uveitis. So I presume in all patients, man-to-man chest X-ray will already be done before you take that call. Assess for active or latent infections. Partly when we do man-to or a quantiferon goal, that's what we do when we are looking for TB. Very important for asking for history of malignancy, for history of tuberculosis, history of HIV, and history of demyelinating disease, especially if you are venturing into giving anti-TNFs, and also history of cardiovascular disease in the past. So many times, people have heard, even the senior most rheumatologists have heard giving anti-TNFs in somebody who's had multiple sclerosis. And multiple sclerosis can also present with uveitis. So, and anti-TNFs are a contraindication in patients with demyelinating disease. So always ask this history. Always good to help. It helps to have a checklist. Just tick that this is not there. Many times when I prescribe biologicals, I do mention that no contraindications to use of biologicals, blah blah blah. You mention all these. The other things are never, if you are using things like, there are drugs which can be used in pregnancy, but there are many which cannot be used. So if there is a young female with uveitis, this is a very important, because this, if you don't take care of this, many rheumatologists have ended up having legal suits against them with the pregnancies, which after the patients have been exposed to teratogenic drugs because they were never told about this. So don't take any of these things casually. So I'll start one by one. We've used azathioprine the most, and it is the general dose is 2 to 3 milligrams per kg per day. But the most important thing is we do not directly start at 2 to 3 milligrams. We start with a low dose, generally 25 to 50 milligrams a day, get a hemogram done after some time, and then increase by 50 milligrams every 4 weeks. You have to be cautious, because sometimes you might end up having severe pancytopenia. And I think I remember one patient who was started very high dose of azathioprine outside, developed cytopenias, and unfortunately we lost that patient in the emergency medical ward because of sepsis many years ago. I think it was 2006-7 probably. Lower doses in renal failure, 50%, generally 50% reduction has to be done. Severe thrombocytopenias can occur if there is a TPMT deficiency. But there is a debate which goes, we have the facility to do for genotype testing for the TPMT mutations, but not all people agree universally that this should be done before starting. Even in up-to-date, if you see people say that they don't really do it routinely, because even if their mutations are not there, even then the patients can develop, because it's not that it is 100% and it will tell you. So, it's not standard of care everywhere. You have to be cautious. The bottom line is start from a very low dose and have to build it up very, very gradually. And this is the most important message that I wish to give when we start azathioprine. The other thing is hepatotoxicity. So initially we'll monitor hemogram. I always get the SGOT, SGPT also done. If they are 1.5 times the upper limit of normal, decrease the shade 25 to 50 milligrams, reevaluate again. But if they are more than 5 times the upper limit of normal, this what we borrowed from the American Thoracic Society guidelines on ATT-induced hepatitis, wherein they say if you have LFTs more than 5 times, you must stop, or you may modify for ATT. But herein you must stop azathioprine. And once the enzymes return to normal, resumes every 4 to 6 weeks monitoring, and then after 2 to 3 months, maybe you can monitor every 3 months also. The other drug which can be used, which is very potent, is methotrexate. Start with 7.5 to 15 milligrams. Why this range? In an elderly, I'll probably start with 7.5. But in a young patient with no other comorbidities, I'll probably start with 15. But the maximum dose is 25 milligrams a week. It has to be increased again by 2.5 to 5 milligrams, depending upon the overall profile of the patient. And we increase it every 4 weeks. The dosage above 15 milligrams, you can use subcutaneous, intramuscular, or oral split doses. Oral split doses have 25% more efficacy. Say, for example, if you reach a stage where you're using 25 milligrams, what I would do is I'll give 15 milligrams in the morning and 10 milligrams at night, the same day, within 12 hours. And, we have to monitor the ACR guidelines. Draft guidelines have been presented at the ACR meeting yesterday. and there also they have preferred oral divided doses over the intramuscular or subcutaneous doses. One has to do the monitoring of hemogram and LFTs initially every 4 weekly and then every 2 to 3 monthly. The other thing which you must never forget is to give folic acid supplementation. It helps with GI symptoms, and with hepatotoxicity there is less stomatitis and mouth sores, less methotrexate discontinuation. This is all established. The minimum dose is 1 milligram per week. We generally have been giving 5 milligrams every day except on the day of methotrexate. But there is now data which suggests that even if the people take it on the day methotrexate is taken, doesn't really affect the efficacy of methotrexate. So if they take it every day also, and many of our populations are as such deficient, nutritionally deficient and all that, probably you can consider giving it every day also. The other important thing is methotrexate induced nausea. Some amount of nausea is common. There is one school of thought which believes that if you can ask patient to take coffee, and coffee has been shown to decrease methotrexate induced nausea. If there is a lot of problem, then you can give MSET on the day the patient is going to take methotrexate. But many times, many people believe that it is more of a psychological, that patients who are supposed to take methotrexate, they start to have nausea even before they've taken their weekly tablet of methotrexate. I've told you about teratogenicity, but I must always also tell you that document it in the card that you've told the patient. And also boldly write it is weekly. You might think that all that I'm telling you is all of you know, but let me remind you, every year, because this is one of the most commonly used molecules, every year we see deaths occurring, at least 1 or 2 or 3, because inadvertently patients taking it daily and coming with methotrexate toxicity, and some of them they're dying because the bone marrow suppression becomes to that extent they come with febrile neutropenia, and we've lost patients, to tell you the truth. Other thing, if you write methotrexate without looking at the RFTs in an elderly population who's diabetic, hypertensive, you might end up ending up with almost the same scenario as above. Creatinine of more than 2 is a contraindication of using methotrexate. And in less than 2 also, if there is renal insufficiency, doses have to be modified. See if you can use something else. Avoid if possible. If there is nothing else you can give, and creatinine is between 1.5 and 2, you can use modified doses of methotrexate. The other thing is, people will be taking annual influenza flu shots. Because if they continue to take methotrexate, then the flu shots may not be effective. So hold 2 flu shots of methotrexate. The other common problem which is there is mucositis. So these, if you are giving lower folic acid, you might give higher. Never forget to tell the patient to avoid alcohol, so rampant in this part of the world. And also look at, why I told you X-ray. If there is interstitial lung disease, it should kind of be avoided unless the physician is using it for sarcoidosis, interstitial lung disease, and sarcoid can also present with uveitis. So there you can use, but in other conditions, probably I'll avoid using methotrexate. But remember, if the patient develops sudden rapid worsening of anemia, thrombocytopenia, ALT more than 3 times or 4 times with nausea, patient is symptomatic, one has to give leucovorin rescue. This is intravenous until the patient has recovered. You look at till such time, you give it till such time the counts start to recover. This is given intravenously. LFTs are less than 2 times of upper limit of normal. This can be life-threatening. And as I've told you, if the patient presents with febrile neutropenia, then you have to become a physician. There are specific guidelines for managing febrile neutropenia. Probably that time I would advise to get the physicians into the picture, because this is really very hot. This is very difficult to handle. So I think probably the physicians should handle it. The thing is that you must also be having scenarios where patient is asymptomatic, but LFTs are between 1 to 3 times the upper limit of normal. Decrease the dose, as I told you. It was 2 times for azathioprine, 3 times for this. Somebody might ask the question. They are based upon what literature is published while the 2 drugs have been used. There is nothing like sacrosanct. You have to look at the overall thing. Between 2 and 3 also, I would probably do the same thing. Decrease the dose a bit, observe, probably do regular testing. My rule of thumb is, you can do if it is more than 2 times every weekly LFT, that if it is more than more than 3 times weekly, more than 2 times weekly, LFT monitoring should be done. Unless if the patient has nausea and vomiting, even at 3, probably I'll admit the patient. So that is what you need to do. The other drug which is commonly used is mycophenolate mofetil. It's relatively easier to use. 500 milligrams twice daily to start off, increase to eventually to 1 gram twice daily, and the maximum dose is 3 grams a day. The most commonly encountered problem is diarrhea, which precludes the use of 3 gram in many of our patients. Rarely leukopenia and malignancies. These are extremely rare. In our experience also, in lupus nephritis, in one of the papers published in Kidney International, done as a DM nephrology thesis, cyclophosphamide versus MMF, surprisingly MMF arm had more side effects as compared to, and more infections, and more side effects. Diarrhea was there, right up there, in making it difficult to reach the maximum dose in some of these patients. The other group is T-cell inhibitors, calcineurin inhibitors, cyclosporine and tacrolimus. The dose again is 2 to 5 milligrams. Generally start with a lower dose. But I can tell you, if you give it for a year, many of them are going to develop hypertension. Renal dysfunction is very high. And I can tell you, if you have an underlying situation which would probably require a long-term therapy, it can't really be given for a very long time because there would definitely be side effects. The other thing that I wish to tell is creatinine is more important to carefully look at when you are using cyclosporine and also tacrolimus, because there is calcineurin nephrotoxicity is there, and blood pressure must always be checked at every visit, more so, and must have a look at it also if you're using cyclosporine and also you're using tacrolimus. Rarely neurotoxicity, hepatotoxicity, gingival hyperplasia, severe myalgias can occur with these patients. Electrolyte abnormalities like hyperkalemia, hypomagnesemia, and hirsutism. So this also, this might have a cosmetic connotation. So you have to keep this in mind. Infections, and rarely there is a risk of malignancies. If you look at, if you ask the nephrologist, they'll swear by doing drug levels and monitoring and titrating the therapy according to the cyclosporine levels. APC biochemistry does that routinely, both for cyclosporine and tacrolimus. But there is also literature available from the uveitis literature which says that routine monitoring is not really required. One of the reasons which I thought perhaps was that while we use 2 to 5 milligrams, the nephrologists end up using 10 milligrams, up to 10 milligrams for renal transplant patients. So this jury is still out. The availability is there in the institution. And if you have to do, there are again 2 concepts. One, the one that is used commonly is the trough levels. Trough levels mean when the levels will be the lowest. So generally the patients, and there should be uniform difference from the time when the patients take the meals, because there can be interaction with meals also. Then if the patient is taking a morning, say 9 o'clock or 8 o'clock dose, 9 o'clock dose, take it 1 hour, the sample should be taken 1 hour prior to the next dose. That is when the trough levels are expected to be there. Same for tacrolimus, the dose is right here, 0.1 milligrams to 0.15 milligrams. The toxicity profile is also almost the same. We've seen press more with posterior reversible encephalopathy syndrome with a few patients on cyclosporine. And cyclosporine is also one thing which I forgot, is also contraindicated in the CNS involvement of Behçet's. If there is neurobehçet's, cyclosporine is contraindicated. Coming on to the most potent and but most dreaded class of drugs, which are not as big a demon as people make them out to be. This wonderful molecule, which has saved so many lives over the years, most of you would can now connect with this. This credit goes to Tony Fauci, or that the world knows as Anthony Fauci, who's been right in the eye of the storm during the COVID thing, and you've seen all of them standing right behind Donald Trump during the COVID. He, along with Sheldon Wolf, there were other reports of Pearson and some other reports where people had used cyclophosphamide in few patients, but they brought this into the limelight. with this publication in New England Journal of Medicine almost 30 years ago, which, they showed that in patients of venous granulomatosis, this did really make a material difference in the patient outcomes. And they found that this alone was good enough to save lives. So what it did, this cyclophosphamide became the backbone. Why I'm bringing in comparison of ANCA vasculitis? Because that's the benchmark, the most threatening disease which the rheumatologists encounter in their clinical practice. And what they did was a uniformly fatal disease with mortality more than 80% or more, came down over a period of time. But everything was not well. The most important concern is infertility for young patients. Although you might still use it in the patients in the elderly population. 2-3 things which I want to tell you with my carefully. The corticosteroid sparing effect is there by and large with most of the drugs here, and drug-free remission patients here are all very small in numbers in the patients with uveitis.
Sir, we lost you, I think, for a minute, for a couple of minutes there.
Okay, should I go back?
You'll need to share your screen, sir. I think the WebEx connection of PJ stopped for a couple of minutes.
Okay.
So we were last, I think, at cyclophosphamide infertility slide.
Okay, so I'll go back. I think it was.
You'll need to share your screen, sir. We don't have your screen right now.
I'll do that right away. Okay. Mm-hmm.
Yeah, it's starting, sir.
Yeah.
So you can go to the infertility slide of cyclophosphamide. We will.
Okay. Right. I'll just go to that. So were we here?
It was before this. It was before this, sir. Yeah.
Here?
Yeah. So we were here. We didn't do anything after this.
All right. So what? Sorry about this. Things beyond our control. Acknowledge. So the other concern which is there is non-melanoma skin cancer. Did I talk about this? Basically the concern is malignancies. And if you use oral dose, the oral dose is 2 milligrams to 3 milligrams per kg body weight. And in a 60 years person, that dose you are going to exhaust in almost 6 months, whereas the literature sometimes says you can use it for up to 1.5 years to 2 years. Never ever use oral cyclophosphamide because there is risk of malignancies. So there is trial data evidence because there were efforts to decrease cyclophosphamide exposure, and there was a Cyclops trial in ANCA vasculitis which showed that there's not much great deal of difference between oral and pulse cyclophosphamide, and no difference in the mortality. And IV pulse cyclophosphamide should always be preferred. The other question which you might have been asked is, people will read about Mesna and ask you whether you use it. If you look at the data, there is not enough data to really tell that Mesna should be used in all patients who are given cyclophosphamide. This was a data-driven review by Peter Merkel from the Vasculitis Research Consortium in US. Evidence from in the rheumatological disease is not very robust. We can discuss with the patient unless the patient strongly wants it. Practically told, I can tell you that we've used in so many patients. We've never had any problem of hemorrhagic cystitis in any of those. We may use it if probably we are using cyclophosphamide again in the second course or later. We always calculate the total cumulative dose that you've used in a given patient, so that we always have an eye where we've reached as far when cyclophosphamide has been used. For how long? This question, you see the site study which suggested that drug-free remissions were uncommon with non-alkylating agents in intermediate uveitis. And if you look at the tables which they've put up, one thing is you can look at these numbers, uveitis under control at 6 months and at a year, and drug-free remissions per patient years with all of these patients. So coming on to the topic, which probably is something which many people wish to listen to. These are the tips, which some of these slides are the same that I had used in one of the USI meetings. So please excuse me for that, but I thought that there might be audience which may not have seen those, but not all of those are the same. So when to use? In generally, if you look at the focus initiative also, it says that the patients who fail on oral corticosteroids as well as another oral immunosuppressant like methotrexate or MMF. But upfront, where if you look at the 2008 update of the BISHES management, an initial or recurrent site-threatening uveitis should be treated with infliximab. So, and they also mentioned that these should never be used, should be treated with steroids alone. So, this is what the EULAR guidelines recommend. So, BISHES is definitely one condition where you can consider using infliximab or even adalimumab upfront. There was a consensus recommendation published in ophthalmology, I think in 2014, which also recommended that anti-TNF drugs should be used upfront as first line of therapy in patients with Behçet's disease. So which one? So whenever I have to take a call, I take a call of biological based upon what is the cost, how much is the efficacy, and what are the risks involved. So what biologicals are available in India? Amongst the anti-TNF drugs, infliximab is available, adalimumab is available, and golimumab is also available, and also etanercept is also available. But in etanercept, there is evidence that it doesn't work, and also there is evidence that it might rather be a cause of precipitating uveitis. So this is one drug which should never be considered, because, and if you come across a practice where ankylosing spondylitis patient has been put on etanercept, and the rheumatologist doesn't really wish to sound that rheumatologist to change this anti-TNF. The other drugs are anti-CD20, which is rituximab, tocilizumab has been talked about during COVID, and IL-17 blockers, which haven't really lived up to their promise in uveitis. Whenever we talk about TNF drugs, there are issues, by and large, they look like similar, but there are differences. Like adalimumab, which is the most commonly, the one drug which is selling all across the world, and number one drug in the world is Humira, which is a originator adalimumab that is not available in India. We only have biosimilars. This is fully human. This is given subcutaneous injection. I'll come into the dosing probably in the next slide. Infliximab, which is given as IV infusion, there is a murine component and there is a human component. Etanercept is a receptor reconstruct Golimumab also is a fully human. Certolizumab pegol is one which is some of these can be used up to, all three can be used up to the second trimester of pregnancy. And certolizumab pegol is one which can be used throughout the pregnancy. I will dwell into it later on. The most important things that you must know that there can be injection site reactions. If you are using infliximab, which is given as an infusion, there can be infusion reactions, especially acute. And so if you are giving the infusion for the first time, both anaphylactic and anaphylactoid reactions can occur. So if you are using for the first time, just don't leave it in the ward to the junior most person who will leave it to the sister and who might become busy taking care of a lot of patients in the busy wards. Make sure that you are active and attentive when you're giving the first infusion. More so, and generally during the other infusions also, because these reactions can occur in repeat infusions also, although the incidence becomes lesser and lesser with each subsequent injection. Hypotension, bronchospasm, wheezing, urticaria. So this all is anaphylaxis, and this requires adrenaline injection, not just Abel hydrocot. And this can happen with anti-TNF infusion, with infliximab. And there can be serum sickness like delayed reaction, which cause skin rash, joint pains, myalgias. So these are of concern, but not as sinister as acute infusion reactions. There can be neutropenias because of the various anti-TNFs. There can be infections, more so tuberculosis. The risk is more with chimeric molecules, which is half humor, half murine, relatively lesser with fully human. I have told you about demyelinating disease, which can worsen. I've told you about heart failure, and if these are a contraindication, if there is a class 3 or class 4, NYHA class 3 or NYHA class 4 congestive cardiac failure. The other thing that you must remember that while psoriasis is also associated with uveitis, which is generally mild, anti-TNF drugs can produce psoriasis-like skin lesions. So if the skin lesions have occurred later in a patient with psoriasis who's been on anti-TNF drugs, that might not be because of psoriasis or psoriatic arthritis, but that might be because of the anti-TNF drugs that you're using. There is always a risk of, always a concern, lurking concern about risk of malignancies with these. Although this has not been substantiated in various studies, but there is some literature, especially in children, where there were increased risk of hematological malignancies. And with anti-TNF drugs, lupus-like illness with ANA positivity can occur if you are using anti-TNF drugs. So if you look at the focus initiative, you can see that adalimumab is one drug which has a level A recommendation. Infliximab has level B recommendation for use and level B recommendation for not using it. Golimumab is also available in India, which has a level C. So adalimumab is given subcutaneous injection every 2 weeks. Infliximab is given as infusion, 2 weeks loading dose, and then initially some people use it at 4 weeks, then subsequently 8 to 12 weeks. And then certolizumab pegol is not available in India. Tocilizumab has some studies showing benefit, and secukinumab also hasn't really lived up to the promise. And rituximab, there are some studies wherein it has been used in Behçet's, and there are some studies after this also where it has been used in VKH also. So you can see all these responding, but you can see the crosses with etanercept, just to driving home the point again. And as I've told you, loading dose is some people employ at 2 weeks, some at 4 weeks. There is also literature from India that if there is higher TB risk, or if the MAN2 is positive and you've given prophylaxis, you might miss the loading dose. Many of our colleagues, rheumatology colleagues, they don't really give loading dose. And some of them, they use lower dose also, 3 milligrams per kg body weight instead of 5 milligrams per kg body weight. It's available as 100 milligrams. Some people use it at much higher doses also. I've never used 10 milligrams for an adult. Adalimumab, infliximab is available both as innovator, which is Remicade, or in is biosimilar, which is Infimab, and there are some others also. Adalimumab, no, innovator is not available. Biosimilar is available. There are many biosimilar, Adali, Dalipka, Adfrar, there's so many of them. Golimumab is only innovator, which is Symphony. It is not available as the biosimilar is not available, and I'll tell you what I'm talking about later on. Biosimilar versus innovators. Tocilizumab, IL-6 blocker, 8 milligram per kg infusion. It can be given over 1 hour. You may not need to give in pre-medication. The unique side effects are diverticulitis. They sometimes can present with abdominal pain and perforation. The other unique side effect which is there is dyslipidemia, and there is increased risk of infections, including tuberculosis also. The other drug is rituximab. We use it quite extensively in our practice for ANCA vasculitis. Also, it is used for pemphigus quite a bit, and I think in our institute also it is being used for pemphigus. Slow intravenous infusion. The first infusion is very, very slow. It can cause severe infusion reactions. So it is given after pre-medication with methylprednisolone 125 milligrams, 2 tablets of paracetamol, and there are 2 dosing schedules. One is 1 gram 2 weeks apart, which is the rheumatology dosing for rheumatoid arthritis, or the one which is borrowed from 3 milligram per kg per meter square, which has been borrowed from the hematology practice of lymphoma. Yesterday, in the day before yesterday, in the ACR meeting, virtual meeting, it was shown that 1 gram is as good as 375 milligram per meter square. One, there will be less B cell depletion. But most important thing is if you use the lower dose, you are ending up using almost 2.7 to 3 grams. So the cost also goes up. So with the upper one, we always practically use 1 gram for induction in most of the rheumatological conditions. Although we use 500 milligrams also for maintenance, and some people use 500 milligrams also. And probably in future we might see lesser doses of 500 milligrams also being used as induction. But as of now, as the things stand today, many people talk about CD19 measurement while giving rituximab. It's not really the standard of care that you have to get CD19 levels every time. In ANCA vasculitis, especially if you're treating scleritis and all that, you might see that we occasionally look at it, look at this PR3 levels and also these levels, but it has been shown beyond doubt that those don't really correspond with we've seen people relapsing even when the B cell repopulation has not occurred, CD19 are 0, or when the PR3 is also 0, even then are relapses. And on the other hand, when there is repopulation, everything else, nothing happens. So to cut a long story short, we don't really use CD19 in all patients of rituximab. So the other tip, I talked about innovators versus biosimilars. Very important. Innovators versus biosimilars may look same, but they are not the same. And the more concern is about the long-term safety. Exactly similar? Are they exactly similar like the generic drugs? No, they are not generic. It's a reverse technology. People pick up the drug from the shelf, look at the chemical structure, make that chemical structure in the lab, do the studies of first pharmacokinetic, pharmacodynamic studies, then phase 1, phase 2, phase 3 trials. And then they show at least one study has to be done to show efficacy and safety before they are marketed. But one has to remember they are not the same drugs with which the studies might have been done. And some unique side effects have also been noted, like with etanercept from Chinese origin. Unique CNS side effects were reported, and that was reported in rheumatology, Nature Reviews Rheumatology many years ago. And those of you who want to read about biosimilars, there is very beautiful review in Nature Reviews Rheumatology if you want to dwell deep into this biosimilar thing. They are also known as there is a difference between biosimilar and biomimics. Biosimilar, for the purist, you have to call a drug as biosimilar if it has either US FDA approval or EMA approval. So many drugs which are available in other countries, especially developing countries, may not have those US FDA or EMA approvals. So they are generally known as biocopies, intended copies, non-regulated biologicals also. And so you have to remember that everything which is marketed as biosimilar may not be truly biosimilar, but biomimic or similar biologic. So already the literature has started to come wherein the other concept in biological is substitution and switch. When in US, in certain states, not in all states of United States, it is in the hand of the pharmacist. If he has a cheaper alternative available of the innovator drug, he can switch. So, people have done studies wherein people looked when there was a switching between original infliximab versus biosimilar infliximab. Some studies have shown that there were flares. This was a small study published in AJO. But there have been other studies which have shown that nothing really happens. In our experience, we largely use biosimilar or similar biological drugs in most of the circumstances, and we haven't really encountered many problems. We, in fact, published our experience of using biological. We've used the word similar biological rituximab. It's not biosimilar because DCGI has given approval as a similar biologic, and we had almost same outcomes in the induction and maintenance, and we've said that this was in a relatively large cohort of 77 vaginal patients. And this paper has really created a buzz. For those of you who are on Twitter, this really created a buzz because this has a lot of connotations for the entire developing world. The other thing is, what workup do we use before prescribing and what would be the contraindications? Always take a history of infections, especially skin infections, cellulitis, other recurrent infections, any TB contact or exposure or family or personal history, hepatitis history, varicella history, or any other high risk HIV risk factors, high risk behavior. As I said, always look whether there is SLE, and if there is lupus-like lesion, we have to avoid anti-TNFs. Diabetes we have to look for because with things like tocilizumab might cause metabolic syndrome. Neurological disorders, I've already told you. Malignancies, cardiac disorders, I've hammered on these points. Hematological problems, lung, any planned surgery or any recent surgery, pregnancy, breastfeeding, contraception plans, and diverticulitis and hyperlipidemia. And if you're using rituximab, we have to do serum IgG levels at the baseline. So some people might be having hypogammaglobulinemia, which might worsen with rituximab. Or you have to, before every rituximab, this is done in PGI for 300 rupees. So I think it can be done. We have made it a point. We do it in every patient before giving every infusion of rituximab. And this hypogammaglobulinemia, the risk increases over a period of time with the increasing number of infusions that you give every 6 months. One thing which probably I forgot to mention, that rituximab 2 infusions are given and then you wait for 6 months. Then you decide whether you give the same reduction after 6 months or you want to give 500 milligrams. The other thing which one must look at carefully is Hep B surface antigen, Hep B and HB core antibodies, HBC antibodies, and HBC antibody and HIV or antigen or antibody tests. If HBs antigen is positive, we'll send to the hepatologist. HCV also will send to the hepatologist. But if HBs antigen is negative, but core antigen is positive, then you do the PCR. If the DNA is not there, just give lamivudine and continue to give lamivudine 12 months after you stopped. This is more so for rituximab, and this is important for the rheumatology residents also to register. That is what you can do. But if this is positive, then probably they need treatment under a hepatologist. The other common question is what to do if the IGRA is positive or if the MON2 is positive and you have to give anti-TNFs. So, if there is active TB on imaging, you will obviously treat for TB. So if you screen for, you've done a MON2 or you've done a IGRA, both are negative, no risk factors, start anti-TNFs. If either of these is positive, do a chest X-ray. If chest X-ray is positive, you will obviously treat for TB. Negative, you've done IGRA, X-ray is negative, you do a CT. If it is positive, obviously you will treat. In chest CT is also negative, then you can give a INH prophylaxis for 9 months, rifampicin prophylaxis for 4 months, or INH plus rifampicin for 2 or 3 months. Why 2 or 3? I'll tell you. There is a difference between different recommendations. And if the clinical condition, then probably you will have to wait for 2 months before you start anti-TNF, even if the clinical situation so demands. And if mild enough, you wait till the entire prophylaxis has been completed. There are different regimes. CDC recommends for 4 months rifampicin, whereas WHO has written 3 to 4 months. So you can look at this. Probably you can decide whatever you wish to give. But one has to remember that there are concerns regarding already INH resistance is up to 50 to 60% in India. That is why the RNDCP has changed the maintenance regime from 2 drugs to 3 drugs. And over a period of time, if you give it just to many patients in endemic countries, there are risk of development of resistance to rifampicin also. So that basically has to be discussed with the patient. That's what I would do. But problems, if you're starting them, always make sure that you tell and document that if there is fever, please report immediately, stop the drug, take antibiotics if prescribed, and not to restart till such time the infection has been taken care of. But also, if there is any other new condition, neurological, cardiac, must get in touch, or any other symptom. The unique side effect of with rituximab is PML. This is multifocal leukoencephalopathy, CNS involvement, which has very bad outcome, JC virus associated disease. But this has been reported with other immunosuppressive drugs also, but came into limelight with rituximab. And again, contraceptive advice has to be given. So special situations, as I told you in the beginning, anti-TNFs have a transplacental transfer. So there is a theoretical risk of infection in neonates, and this increases if you continue to give after 22 weeks of gestation. And the other thing that you must remember, if there is a young lady, or in the peripartum period have started this, the vaccine also, if the pregnant lady has been given anti-TNF, some vaccines have to be some vaccines have to be provided in the children in the first 6 months. So as I've already told you, certolizumab pegol is one which is compatible with breastfeeding, compatible with, all the anti-TNFs are compatible with breastfeeding. Infliximab, you have to stop at 16 weeks. Etanercept, we are not going to use. Adalimumab, second trimester, but not in third trimester. Certolizumab in everywhere. We don't have it available, unfortunately. And for golimumab, you don't have data. So if there is a young pregnant lady, you do have golimumab available in India, but you can't use it. But for tocilizumab and pleximab, you can't really use in this population. Again, you don't have to mug this up. Just remember that you have to remember that the vaccination should not be given to a child who has been given this biological therapy. And the last thing is that all patients who are either on synthetic DMARDs or biologicals, they must always be offered immunization. You can keep this on your desk or on your smartphone and refer to it. But remember that these have to be given a priori before initiating therapy when you are using DMARDs or combination therapies. And you can also, if this has not been done, you can also do that while they are taking therapy. The other thing is that if there is a planned surgery, then anti-TNFs or all biologicals should be stopped at least 2 weeks prior to therapy. And before restarting, you make sure that the wound healing has occurred and the specialists they are happy for you to start. But if there is an emergency surgery, then it has to be done, and just inform that there is increased risk of wound healing. The last but not the least, this is borrowed from Jim's Rosenbaum's write-up in arthritis and rheumatology. This is obviously a rheumatologist's view, and you can pardon me for but I've just reproduced it. Finally, although some ophthalmologists are comfortable prescribing immunosuppression without close physician collaboration, which fortunately is unfortunately for them, but fortunately we have a good collaboration here. This is not an issue in PGI. Our forefathers, Professor Amod Gupta and Professor Bambri, put this in place. I think it's more than 3 decades, probably 4 decades now, ever since they started to practice this together. So, but what is written here for other people is that virtually all ophthalmologists lack an infrastructure that is prepared to deal with systemic infections, which are rare but unavoidable. So if you're going to use these big guns, you're going to have some test coming up, which will come on to the foot soldiers also, or all the infrastructure. This is inevitable. So I think so the collaboration is the key. So you can choose which one you want to be, but I think it has to be there, and we fortunately have it. And these are the key references. I think you can note down some of them. They are really worth looking at once in a while or referring to. I'll wish to conclude by saying that the management of uveitis definitely needs close collaboration. Careful screening before initiation and requires follow-up for monitoring of efficacy and for adverse effects. Thank you very much for your patient hearing, and I don't know whether I've exceeded my time, but I hope that Chairperson ma'am will probably pardon me for that.
Thank you, sir, for the very informative talk. I think we have about 10 minutes. Dr. Diksha is there. I think ma'am can go ahead with the questions.
Okay. I think I am having a problem in viewing. That's why I had asked.
Okay, I'll go ahead, ma'am. Okay. So, sir, main question related to pregnancy. Which immunosuppressive is safe in pregnancy, if we were to choose one? And again about conception, that how can a person conceive after stopping immunosuppression? If so, after how much time? Two related questions to that. So you need to unmute yourself, please.
Sorry, can you hear me now?
Yeah, we can, sir.
Yeah, so the question is which ones are safe? So azathioprine is safe, and for both pregnancy and lactation. Cyclosporin or calcineurin inhibitors are safe. Anti-TNF drugs, infliximab you can use in first trimester. Adalimumab you can use up to the second trimester. These are safe. The one which are big no-no are the rest. You can't use MMF, you can't use cyclophosphamide, obviously as a big no. You can't use methotrexate, and which else are left? You can't use rituximab. So I think the only ones which are left are azathioprine or cyclosporin or tacrolimus. These are the ones which can be used. And the lactation also by and large holds the same. Some people say you shouldn't get azathioprine during lactation, but there are other recommendations which recommend that you can use.
Simar, we can't hear you.
Simar, we can't hear you.
Yes, sorry. Second question related to this was about conception. Can a woman conceive after stopping
Sorry,
immunosuppression?
all right, I forgot. As a rule of thumb, 3 months after the drugs have been stopped, they can plan. For methotrexate, 3 months. There won't be any issue with azathioprine. There won't be any use with MMF. The other things which one has to take care of is that even if you haven't used it, if the patient is on leflunomide, there are some mentions of some people using leflunomide for rheumatological conditions, and there is some mention of it being used then you have to give a washout before you really tell them, because that is one drug which will stay in the body for years together. So therein, we don't really use it. We have never used Uveitis here, but you will get patients referred from everywhere, and someone might have started it. So that time you have to be careful that if there is a plan, then a washout has to be given. Anti-TNF, there is no issue for infertility. None of these drugs, barring cyclophosphamide, as such causes infertility. Cyclophosphamide is the only drug which causes infertility. The other drugs don't cause infertility, but they have teratogenic. So some of them have to be avoided.
Aman, regarding the stoppage of biologics prior to surgery, would it be applicable to ocular surgery that will be done under local anesthesia as well?
Ma'am, generally the concern is increased risk of infections and wound healing. Probably in eye surgery, wound healing is not as big a issue as would be with the other surgeries. So, and if it is imminently vision threatening, as I've shown in the slide itself, and this takes precedence over waiting, you can go ahead and do and just tell them there is a minuscule minor increased risk of infection, which would any case be there when somebody is on anti-TNFs.
And the second question that I had was, like our patients, sometimes we use biologics as a stopgap and to break the cycle of inflammation. Because instead of adding a second immunosuppression, we just want to add biologic to azathioprine. So, though we don't have a very specific protocol for it, but do you think we give it for, say, a period of 6 months, 8 months, and once we reach a comfortable zone, is it possible just to continue with pre-biologic immunosuppression and wean off from the biologics?
I think that's a very important and the most relevant thing that we have to keep in mind always. And that is what we are going to do practically. Almost all of our patients are never going to afford biologicals for their lifetime. I mean, unless somebody has insurance or from the government sector, they are not going to afford. So to cut long story short, how we do it is that I'll probably keep, once we have reached a stage where we want to give anti-TNFs to control, we'll probably use her for a year and a half. Once is for a year and a half, then we'll probably stagger. Say, for example, if you're using maybe at year, these are just looking at the eye. If it responded very quickly, there's no sequelae, maybe after a year you can increase the duration between the, so from 2 weeks you increase it to 4 weeks, and then you increase it to 6 weeks. That also you do. And there is some experience which is not really published, where people have used infliximab doses every 3 months, every 6 months, every 1 year also. People have given 1 year also, and they've seen that, that kind of jugglery. This is basically a jugglery looking at how much eye is inflamed or how much rheumatological disease is compelling us, and what options do we have, and what is the affordability. Because real life scenarios are different from the trial scenarios.
And can we, some of our very fulminant diseases, only ocular, I'm not talking about systemic, can we start corticosteroids and biologics at the same time, IV?
Yes.
And we do have to follow it up with oral always, or can biologic take over in a week's time, 10 days?
Ma'am, generally anti-TNFs, they act very, very fast. Generally anti-TNFs should be acting faster. You can give a bridge for some days, but you can rapidly taper and stop steroids. If you look at,
can there be an alternative to IV steroids? Like if they're acting so fast, I have been wanting to do it, but I have not been able to do it.
You give IV
I have confidence in them as I have in steroids.
Ma'am, अभी तो ऐसा है कि if you borrow the experience from patients, I think, which is the product, right? So I think you can do that. In a given individual patient, it can be done. We don't know for in how much time does it really start to kick in. I think, although I have had one slide where there was talk about the T halves, but I think that can be done in a given selective patient. I can't say that it can become the practice, but in a given patient, for sure it can be done. People have used various combinations also. You see, if you look at rheumatology practice, this is pure science, theoretical. But in the real battleground, people have used cyclophosphamide plus rituximab.
That was my next question. Sometimes, very severe bitches and all.
Yes, people have used it.
Caught between cyclophosphamide and biologic. Like, I want to give biologic, patients go to rheumatologist and they say, "Ki wo keh rahe hai cyclophosphamide de do."
Cyclophosphamide, for uveitis, we generally don't use upfront cyclophosphamide. If the patient is affording, we always talk about anti-TNFs. But there are scenarios like if it is a scleritis. Scleritis, we know that cyclophosphamide will work wonders.
Works well.
That's not a problem. So in scleritis, we will give cyclophosphamide. But in other uveitis, for example, Behçet's disease, you will probably be more prone towards using anti-TNFs. But the problem is most of them, they don't afford. I mean, you might have seen my notes. When I used to put notes, maybe I've never not put notes for some time now. So I used to write, documented that the patient doesn't afford. So I think your point is very well taken. The other thing which I wanted to sensitize, although I crammed it with rheumatology literature, was that I wanted to sensitize the DMA residents that the world is moving towards lower and lower corticosteroids. And probably we are near that point where probably we'll be doing away with steroids in rheumatology. And most of the things have been co-opted from rheumatology that might come to UVA to ophtha practice also.
And this avacopan will be minus the side effects of corticosteroids?
Yeah, ma'am. They have compared the GTI, glucocorticoid toxicity index also. There is a great deal of difference. That was John Stone's group had brought out an instrument called glucocorticoid toxicity index. We have that instrument with us. And I think we can make a plan to, we see how our patient do with steroids. But yes, steroids, that was the major advantage with C5a inhibitors. And that is why people want to go.
Oral cyclophosphamide these days?
No, it's a big no.
Okay.
That is why from uveitis perspective, those many cyclophosphamide slides were not required. But I said that I have to write that point home, because it will cause cancer. You will reach 30 grams in 6 months. Please do not use it. Even if you read the write-ups of drug jabs, I've looked at the literature. Wherever they've talked about cyclophosphamide, they've talked about oral. Please do not use it. Even in a life-threatening condition like ANCA vasculitis, where the patient might die next day, we use IV. So don't use oral at all if they have to take one message from my talk. Never ever use it. It's very toxic. But it is a beautiful drug at the same time if you use cautiously.
And when we start our non-TB patients who are negative all the tests on anti-TNF, do we have to repeat Montu's or quantiferon or whatever? No, unless the patient has some symptoms.
Unless the patient is symptomatic. If the patient is symptomatic, they are going to treat for TB.
Then it's fine, but otherwise not as a screening or anything.
No, because then basically you already screened for latent. Then if at all anything will happen, it will be a disease, and it can happen. TB can still develop even if you screen. So it might be sitting in some focus in the bone somewhere. You know, you can't the latent therapy is not going to reach everywhere because just using one drug or two drugs. But TB bug might be sitting anywhere, and what you have given for a prophylaxis may not reach there.
Okay, so there are a couple of questions. Simar, you can go on.
So quickly, we have 5 minutes. I'll just ask a couple of questions we have. So Dr. Atul, our MCH students, he wants to know that patients developing cytopenia on immunosuppressive therapy, should we start hematinics and continue on taper immunosuppression? Are there any specific levels of TLC and hemoglobin below which you would plan to stop or taper the immunosuppression?
We, as a rule of thumb, quickly, HB less than 8, TLC less than 4,000, and platelet around or less than a lakh of platelets, you stop and look for other things. So one thing is the resident sometimes becomes scared at 9.8, 9.9. So with methotrexate and azathioprine, you would have seen that we are reasonably comfortable. And at the same time, definitely look for other causes. Do a peripheral blood film, look for iron deficiency, give iron supplementation, look for other causes and supplement. But if HB is less than 8, some people say 7 also. If you look at the published rheumatology protocols, we had that figure at 7, but I'm more comfortable at 8. I mean, this is basically, we would probably try stop it for a while. TLC definitely less than 4,000. And platelet maybe 80,000, 90,000, but the book picture is a lack of platelet count.
Right, sir. Then Dr. Aditi wants to know that if the regimens that are described for uveitis, would the approach be different for other systemic entities of the eye like orbital or lacrimal inflammation if we were to give immunosuppression?
I think that really has to decide because uveitis people describe their regimens. So
yeah, basically the regimens have been borrowed from rheumatology practice, and by and large they are the same. The frequency of the drug and the drug usage, even within the rheumatology community also, within different disease conditions, they are largely the same, and the same has been continued in uveitis also, by and large, whatever I looked at.
Yes, we have a couple of questions from our cornea colleagues who look at the ocular surface. Dr. Jitendra wants to know if the immunosuppression of choice for cicatricial pemphigoid from your experience.
I actually am more comfortable sending them to dermatology, but I get direct requests for rituximab. I think rituximab has become the standard of care. So all those things which I've told regarding rituximab have to be taken care. There is a lot published from our institute on these bullous disorders from dermatology. They've done some good work on rituximab.
Right. Last question I think I'll take from Dr. Barkha. She is a MCH cornea student. Vasculitis associated scleritis like in GPA, IV cyclophosphamide or rituximab? I think you answered that earlier also.
Cyclophosphamide unless there is a fertility issue in a young person, or there is a total cumulative dose is more than 30 grams, or it's never, people tolerate it reasonably well. It's very safe and a beautiful drug if you use it judiciously.
Right. So I think we have a next class starting in a few minutes. I'll give over to Dr. Vishali for the concluding remarks.
I think last question is HLA-B27, methotrexate or sulfasalazine? Sulfasalazine.
And there is a reason also. There is a gut inflammation which is driving this, and the gut microbiome studies have shown there is gut inflammation. And to calm that gut inflammation, sulfasalazine has a role.
Perfect. Aman, yours so far has been the most popular lecture of the session, so which indicates that you have to come back to us more often.
And you have to order, ma'am. I have always a cherished relationship with Eye Center.
We'll have more and more from you. That would always be wonderful for us to understand, and so that we can manage with your junior staff and not bother you all the time, because if we understand, we are.
One thing I would, on the passing note, I'm still available 24/7, 365 days at the Eye Center.
It's always a pleasure, Aman. Thank you so much.
All right. Thank you very much, ma'am.
Thank you, sir.
Thank you so much, sir. It was a wonderful lecture.
It was amazing, full of
Thank you.
learning.
Yes,
Thank
full of learning. We learned so much.
Okay. Thank you.
Thank you, sir.
Okay. Thank you.
Okay, Aman. Thank you.
All right, ma'am. Okay, I'll sign off. Okay. Thank you.
Bye.